All right. Today's topic is actually an adverse effect that some people develop from cannabis use over time called Cannabinoid Hyperemesis Syndrome, or CHS. CHS is a condition characterized by reoccurring episodes of severe nausea, vomiting, and abdominal pain in individuals who use cannabis regularly over an extended period of time. It's quite paradoxical because cannabis is often used for anti-nausea or antiemetic properties. Yet from CHS, these symptoms could actually arise from chronic cannabis use. Patients with CHS may find temporary relief from hot showers or baths, or from rubbing capsaicin or hot pepper cream on their stomachs. This is a distinguishing feature of this syndrome compared to other syndromes that may cause other types of vomiting. There is very likely a genetic component to CHS, so not everyone who uses cannabis is equally as likely to develop it. And we will discuss that as well as some other theories on CHS throughout this episode. We are releasing this episode today because we are running a study on CHS right now at this very moment when this episode drops in October 2024. This study is being run through the University of California, Irvine, with myself, today's two guests, Dr. Codi Peterson and Mbengue, as well as three other amazing researchers who we'll mention in this episode. CHS is very real, stigmatized, and often misdiagnosed. The goal of this study is to learn more about the signs and symptoms of CHS and what may be contributing to its triggers. The links to part 1 and to part 2 of the study are going to be linked in the show notes. 3 people from part 1 and 3 people from part 2 are going to have the opportunity to win a total of $600 if you sign up for the raffle after completing the study. We really appreciate you taking the time to contribute to science, so we wanted to give back in any way we could, which is from raffle prizes. So during this episode, stretch your legs, check on your plants, grab a glass of water, and just chill with us for the next hour or so. All right, welcome back to the Bioactive Podcast. I'm your host, Dr. Riley Kirk. Today we have 2 guests with us, Dr. Codi Peterson, also renamed Dr. Codi Weederson on the last pod that you were on here.
Oh, yes, that's right.
And Mbengue, who has also been here a lot, or a couple of times, I should say, who is a cannabis nurse. And the topic of today's discussion is CHS, or Cannabinoid Hyperemesis Syndrome. And this is a serious topic. It is a serious podcast because there's not a ton of information out about CHS. It's sometimes questioned the validity of it, which I think is kind of egregious. It's absolutely real. It's absolutely happening. So we'll start there. But let's start with talking about what CHS is. So, Codi, can you just kind of start from just 30,000 foot view? What is CHS?
And I would just stress that this is very much real. And in the hospital where I work not every night, thankfully, but where I work full time, is we saw a patient that fits this mold perfectly just last night, within the last 12 hours. And this is a patient who's experiencing repeated bouts of nausea and vomiting that is uncontrolled with normal antiemetics. And that individual has been consuming cannabis, most likely high THC cannabis, for an extended period of time. So it's an unexplainable vomiting that is refractory or resistant to our normal medicines that is in someone who's been smoking a lot of cannabis. And interestingly, hot baths and showers. Patients often find relief or have a tendency to start taking hot baths and showers. So that's sort of like the hallmark classic case of something known as CHS.
Love that. Can we also discuss how much vomiting? Is this oh, I hit the bong and I puked after? Or is this like a lot of vomiting?
Megan, you're welcome to chime in at any point. I don't want to cut you off, but the answer is...
Oh, yeah. Honestly, anyone answer at any time. I feel like we all kind of vibe all the time. So
we'll flow.
Go for it.
Yeah, I think there's it is important to differentiate between vomiting caused by acute intoxication versus CHS. Somebody who had their edible story, they just had too many edibles and then vomited after. This is not CHS. This is somebody who's been using cannabis for a long period of time depending on the type of cannabis and that amount of time. And then there's a series of events that happen before they even get to the vomiting phase, and we can cover that. But the vomiting, I think it's like, for some people, it's a couple of days that it lasts. A lot of people end up in the hospital and with severe dehydration. And we've seen severe organ damage and even people dying of this.
It's an unfortunate truth, but I think that Megan makes a really good point. I'd love to talk about what leads up to this, but the intensity of the vomiting is remarkable. Often people are described as screaming and vomiting at the same time. There is an immense amount of GI distress, pain, uncomfortability, sort of cramping, as opposed to, say, when you've smoked too much cannabis and maybe you were drinking with your buddies before, you're likely to get more of that typical like lightheaded vomit acutely, feel a little bit better, lay down and sort of shake it off. That is not what's going to happen here. In fact, it's likely you're going to have continued episodes over the period of hours or even days where you can't keep anything down. You can't think of food. You can't tolerate anything by mouth.
Yeah, and this is really important for the cannabis community because at least for me, if I'm feeling nauseous, if I'm feeling sick, if I have GI issues, I might smoke more weed. You know, I might be like, oh, my stomach hurts or something's happening with GI issues. I'm going to hit the bong to make sure that, you know, my stomach can calm down. And this is where a lot of people's thought process goes, and they end up using more cannabis, and it perpetuates the issue further and further because a lot of people don't know about CHS, so it's hard to tell those signs of when it's starting. So I think we were kind of getting into the conversation of the prodrome phase, or what's happening, you know, before someone gets really, really sick. So I think you were starting to say that, Megan. Would you want to?
Yeah. So prodrome is technically like phase 1 of CHS, and this can last for weeks, months, or even years prior to the first vomiting phase. And typical symptoms we see are people wake up with nausea. They start having heartburn. Alcohol intolerance is surprisingly a big one that a nurse friend of ours sees in a lot of her patients. Codi, what else do we see in prodrome?
Like a morning heartburn, particularly pain above the belly button. We see individuals who are waking up very sweaty or anxious in the mornings, who don't feel good in that, especially that early morning time. And once again, these individuals are typically consuming cannabis for long periods. And when they consume cannabis, say on a day they wake up feeling icky, it might help a little marginally, right, during that acute phase, but that's actually what we believe to be what's setting them down this path in the first place, and it can be a really challenging condition to better understand.
Wait, I think this is a really good point right here to plug the study that we're doing. You might notice a lot of what we're saying is like, oh, we see these trends, or we think this is happening, you know, a lot of hypotheses. But we are starting a study. When this podcast is released, the study will be out, and it'll be linked in the show notes of this episode, as well as our social media channels and the links in our bio and all of these different places. But we are running a study that's a 2-part study, and it's quite long. I will warn you about that. It is long, but it's long because it's incredibly in-depth, and we're trying to get to the bottom of some of these questions that we have about CHS. So this right now, I'll plug this a few times, but if you or somebody you know suffers from CHS, please fill out the survey, the study linked in the bio, and you have the opportunity to win $600. So $300 for completing. 3 people can win $300 for part 1, and then 3 people can win $300 for completing part 2. So we wanted to give some sort of incentivization to finish these studies, and we really appreciate the people who are willing to take their time and contribute it to science. It really, really is going to change the way that we understand and think about CHS.
I've learned the most about this condition by asking my patients directly, hey, is this happening to you? And I see cannabinoid hyperemesis, you know, probably once a week or once every other week at the hospital. This is not some immense wave of patients coming in. But keep in mind, I work with kids, right? Under 18-year-old individuals. And you know, it's happening, and it's very clear. It happens in a very stereotypical pattern of not feeling well for an extended period of time, starting to have a bout of vomiting. Typically, they go to the hospital. They check all the things, and they don't see anything. They go home, and they're still vomiting. They come back to the hospital. This is exactly what happened to my patient today. She was at the emergency department on Wednesday. The family is in town from Canada, going to Disneyland. You know, we had a spicy, fatty burrito at Disneyland that set us off into this vomiting episode, which we also see with CHS. Another funny thing that we see is it seems to be some food intolerances and sensitivities. And
spicy foods? Are we kind of alluding towards the TRPV receptors, TRPV1 maybe?
Yeah, maybe. I think there's good reason to scientifically go that way, but I also think we don't understand this condition very much, and we're really trying to reach for what might be an intolerance. So that's why we need your help, and you or your friend, make sure you send them this flyer so that we can better understand what intolerances you might be experiencing, so we can get this into the literature and get it into the hands of doctors so that when they're treating you or your friend or your cousin in the hospital, they don't go down the wrong rabbit hole, or they don't miss this very clear evidentiary thing, or they don't get it wrong, right? That happens sometimes too, is they don't jump to that conclusion just because you're a cannabis user and you deal with nausea and vomiting.
Yeah. Right. That's a really good point to make. I remember when I was last in the hospital, when I almost, cut off my thumb with that whole incident, I was there getting stitches, and I was talking to the person the doctor that was stitching me up. And she's like, what do you do for work? And I'm like, I work with cannabis. And she's like, oh, we see CHS all the time here.
The first thing
she's like, the only thing that helps. Oh, yeah. And the only thing that helps are cold showers. And I'm like, wrong.
Cold.
But really, that is a problem because she was not educated on the subject. She knew that what CHS was, but she was saying that cold showers helped. And I'm like, that's just not true. So part of the reason we're doing this study is to essentially provide a infographic for people in hospitals, for people who work in hospitals, to quickly identify CHS and to not prescribe them the wrong drugs and to not send them home just because they're cannabis users and we're, putting off their experience as not real. So I want to just put that in there as there's a lot of people who don't know about this, who are uneducated about this, whether you're a healthcare professional or a cannabis consumer, and we all need to know about this so we can spot it in our community and we can kind of help in that way too, or just share information about it.
This isn't a condition that's easily diagnosed, right? If you had the flu, you come into the hospital, I take a little swab, I stick it up your nose, I send it to the lab, it comes back, all these symptoms you're having are because of the flu. Congratulations, here's your diagnosis. We've got a plan. We know what to do. With CHS, we have to exclude everything. When you come in with this intense vomiting, I need to make sure you don't have appendicitis. I need to make sure you don't have an ulcer. I need to make sure you don't have, some bowel obstruction and so many other things, like a dozen or more. And it's expensive. It's costly, it's invasive. There's a lot of problems associated with it. So we have a long way to go to making things easier. As it stands right now, the only way to diagnose CHS with the poor diagnostic criteria that's technically agreed upon is to quit smoking cannabis for 6 months to know if it's actually CHS. That is the only definitive way to technically diagnose CHS. So we have a long way to go, but we have to get the help of the people who are afflicted with this condition. We need better data.
Right. And I think that the symptoms are also so nuanced. I used to think that okay, people smoke a lot and then it causes vomiting. But what we see is people use the cannabis and it helps with their symptoms a little bit. And then, and then it perpetuates episodes. And sometimes the withdrawal phase triggers episodes and triggers these symptoms. So when you start abstaining
from cannabis, it's triggered. Okay.
Right. I had a 17-year-old here who he didn't go into a hyperemetic phase. He was only in prodrome, but would wake up with morning nausea, anxiety. He went on a school trip and then he wasn't consuming during that school trip. And then he started having all of these terrible symptoms that very closely resembled CHS in that withdrawal period, the 2 to 3 days. So it's a really fascinating, is that withdrawal or is that CHS. And
we've talked about this before, right? So like this group of us meets and where we've been working on the survey that we're going to launch and everything. So we've kind of chatted about this before, but Megan, and there's no consensus on whether this is happening and where withdrawal falls in abstaining from cannabis falls into the CHS episode. But I would point out that my patient today was on vacation and was not consuming cannabis for the last 5 or 6 days. And, here we are. So it was just a funny, you've been talking about this on the last meeting. There could be something here. One thing that's not known, and I think this is probably a good time to jump into this, Riley, is what's causing CHS.
Yeah, 100%. Let's get into and this is going to be theories, by the way. We don't have an answer for this.
No one has an answer.
This causes CHS. Yeah.
The answer doesn't exist.
Yeah, we don't have an answer. Yeah, but I think it's good to talk about because I think people are worried, specifically people who dab. People who dab are very worried because we often are attributing high doses of cannabinoids to CHS being a cause of CHS. That might be related in some way. And I'm just going to say, from my perspective, I think CHS is kind of your endocannabinoid system being off kilter, being off balance. Like we've exposed it to too many cannabinoids, and in typical situation, say you have inflammatory gut or say you have chronic pain and you're using cannabis to balance out your body and to help with those symptoms. Well, like anything on earth and nature, it can go into balance and it can go out of balance. And if we throw these systems out of balance, we know that the ECS is controlling everything in our body, including things like nausea and appetite. And I do believe that CHS is a product of your ECS being thrown off balance and causing some of these adverse effects from this whole system being off kilter and exposing it to too many cannabinoids. But we should talk about other theories.
Well,
or this
I think the theory of imbalance, opens us up to a lot of potential problems. But look, we know this is highly correlated. You can't even argue it. Individuals smoking high THC cannabis are far more likely to develop this condition than anyone else, right? That is the correlation. Yeah. Now, the question then becomes, what is in that high THC cannabis product that could set us off? Now, you could, and like the internet has, you could reach for, perhaps it's something that's been sprayed on that product. Perhaps it's a pesticide. Neem oil is frequently cited online as the causative agent. And it's true that acute exposure to neem oil can cause acute vomiting. But there's no evidence that neem oil presents in this cyclical fashion, with patients presenting with a prodrome, repeated bouts of emesis, or a hot shower. So that really doesn't explain any of that.
That withdrawal piece too.
Okay, you're totally right. If it was the toxicity of an acute exposure, and this is what physicians that I've talked to in this space, because I'll take the theories from the internet, I'll be like, hey doc, you're a toxicologist, what do you think of this? And the problem becomes is these patients do not fit a classical, what's known as toxidrome, a syndrome, kind of like a prodrome, the pre-symptoms, the syndrome of toxicity, toxidrome, almost always continues to present itself in a very consistent way. And almost exclusively that toxicity is seen when drug levels are highest in the body, which means right after you would consume the cannabis. And that's not what we're seeing. We're seeing relief. And then we're seeing them get CHS or an episode 2 to 3 days later or months later. So that doesn't make a whole lot of sense to me. You would then have to look back at the cannabis. What is abundant in this thing that we're smoking? Okay? And if you get down to it, if we're talking about concentrates, 80 to 85% of that concentrate is THC. If you're talking about modern flower, 25 to 30% of that flower by dry weight is THC. It's certainly not that much pesticide. It's not that much terpene of any of the varieties. So the most guilty looking party is THC. Now I know that's bad news. It's my favorite too, and that's not great. But it's also this master key to this regulatory system that we discovered. It helped us discover the system that actually explains quite well all of the symptoms we're dealing with. The prodrome, waking up with difficulty balancing your temperature, feeling hot, feeling cold, sweating, feeling anxious, your heart racing up and down. These are all correlated to the endocannabinoid system without even a stretch. We know that's what the ECS does. And I could keep going, but, I'm going to let someone else talk.
Megan, you want to talk about any theories? I love talking about the theories. Like, honestly, whenever I post something about CHS, I mean, the comments are always an absolute pleasure to look through. Because honestly, we don't know. So it is very interesting to get community theories because people do care about this a lot and they want to know for our community what's causing it and how to avoid it, obviously.
Right. We love this plant,
right.
and we'd hate to see it, be
Yes.
the bad
Yeah.
girl.
Yeah, we're not making this episode to like fearmonger people away from THC. I mean, I've already used THC today and I'm going to use it later too. But the point is just having a resource for people to know what those signs and symptoms are and to participate in the study if you have suffered from CHS.
Or know someone.
Yeah. I think what's interesting too is, people are like, well, we didn't know about CHS up until 20 years ago.
True.
So why is it just now that we've like commercialized cannabis? And so it's got to be like the growing conditions and this mass production, but also concentrates. Were concentrates a thing prior to the 2000s, that we've really seen this explosion in concentrates in the last 10 years and this like explosion in CHS at the same time. And what I've seen in people coming to me with CHS is they've, somebody was just using that 17 was using concentrates for only a couple of months, like 2 to 3 months, I think. And then in his withdrawal of it, he started experiencing these symptoms.
GI symptoms.
And I think what we see is people using flower tend to be like, oh, I've used for like 6 to 10 plus years. And then they start developing symptoms. Concentrates are much, much shorter, oftentimes less than a year of using concentrates. And Codi, what do you see at ED?
Yeah, that's an interesting correlation. So once again, I work with pediatrics. And, it doesn't take very much reasoning to see what kind of products are kids going to be most likely to be consuming. It's not rolling up flour and smoking a fatty outside the gymnasium, right? It
ain't that Cali syndrome.
Yeah, it's like the humble, mixed light. No, it is a vape cart. And that's what they can get. That's what's concealable. That's what's all of the things. So they're almost always exclusively smoking vapes. But again, if you looked at statistically what my patient population is smoking, they would be vapes anyway, like whether they get CHS or not.
Yeah.
So I don't have an answer. I want to know. We ask about it in the survey. We want to know more. We want to know about your use patterns, what you've been consuming, what changed recently. But we do know definitively that concentrates do produce in like sort of that one puff per shot, a higher blood concentration than you will achieve with smoking. There's evidence to say this. The van out of Colorado did some drug levels, and they saw when people titrate with concentrates, they shoot a little higher than if they titrate with smoking.
And that's why a lot of people love concentrates.
Right.
They need that higher dose, It feels better to them, but this is important to talk about anyway. But it doesn't mean all concentrates are bad. It just means that some people do have an adverse reaction.
That part, I wanted to get to that. So Ethan Russo, who he's like one of the demigods of the cannabis industry. We all love his paper. We're really fans of the entourage effect, which is what Ethan Russo postulated. So if you're big on THC and CBD work better together and limonene helps this, and thank Dr. Russo. Now, Dr. Russo also has an opinion about cannabinoid hyperemesis syndrome, which is A, this is not pesticide contamination, and B, it's likely endocannabinoid system imbalance due, at least in part, to genetic abnormalities. So he did an evaluation of a unfortunately small, but still found it to be statistically significant group of people who, if you had CHS compared to non-CHS pot smoker controls, right? And they looked and they said, who smokes cannabis and doesn't get CHS? Who smokes cannabis and did? What genetic differences they had? They found 6. And some of that has to do with the hot chili oil, TRPV, we talked about earlier, but not just that. It's just like a lot of brain enzyme stuff that goes on. So we think there are people who are genetically predisposed. And to Megan's point, we've never had this much THC available to this many people at all. It's so easy now.
So we have a larger genetic pool now where more and more people are actually using cannabis, using THC. So we are seeing the rates go up because more and more people are using it. And I do think the genetic thing is really, really important because I've seen comments too of like, my brother got CHS and I have CHS too. And I think that's kind of, I'm not saying it's like comparable to schizophrenia, but in my opinion, if somebody in my family had CHS, that's when I would start being worried about using concentrates at high doses and stuff, because you know that you very well might have that same genetic change that would make you more likely to get CHS. So I think that's an important point to make, that we've seen that within the community, and we have Dr. Russo's evidence that there likely is a genetic component to CHS. So everyone's not equally susceptible to this condition.
I think it helps break the stigma a little too. This is one of the biggest problems with this condition. We have ostracized people who've come out and say they developed this because they're talking negative about the plant, right? Look, I love this plant, but it's not perfect. Nothing in this world is. And if you're willing to die on the cross that something's perfect, I promise you that's where you'll stay, because that's not the way the world works. And cannabis is an amazing medicine for so many people. It's even amazing medicine oftentimes for the people who develop CHS. It can still be both. It can have a side effect profile and be medicine. I got so into my point that I don't remember where I was starting off.
Wait, let's talk about that point, though, because this is a common question of people who get CHS asking if they can still use cannabis at any point in their life, or hemp CBD products. Do we know the answer to that?
So Katie, our nurse friend who part
of our team for this study as well.
Part of our team, and she has been like pivotal in this study because she deals with hundreds of people directly with CHS. So her mantra is, you can never use without some degree of symptoms. So for some people, like, I think that perhaps they can go back to using a small amount of low percentage flower sporadically. I don't, going back to using heavy concentrates, I don't think is realistic for a lot of people.
And what about CBD products? Could you smoke a hemp joint,
I think
CBD
some,
donut?
I've heard that, this is what we're going to find out in the study. I've heard that can often trigger a lot of people also, because it's still activating our ECS.
Yeah, there's definitely anecdotal evidence that CBD can be a problem. We haven't really well evaluated maybe like a CBG or CBGA or CBDA or THCA. So there's a lot of therapeutics out there, but generally for both THC and CBD, it's pretty well agreed that this can trigger a problem. However, I have literally seen the entire spectrum of patients reporting this. Some people, they had CBD, it made the condition so bad that they went to the hospital. Other individuals say they switched to hemp cigarettes and that's all they smoke, and they've gone about their lives. So this disease is occurring on a spectrum, and we won't be able to put everyone in there. But there is something about this disease that isn't a spectrum, which is the set of conditions leading the prodrome, which we can talk about one more time before we're done, and then the hyperemesis, these vomiting episodes that are unlike the other vomiting that we typically have in our lives. You'll feel that it's different almost.
One other thing that we included in the study that I think is important to talk about, because I've been making content on this recently, is the synthetic cannabinoids, these hemp-derived compounds, whether it's Delta-8, HHC, Delta-10, THCO, THCP, whatever it is. These other ones, these other cannabinoids that are not being extracted from the plant, but are being synthesized in a laboratory. I've seen so many comments that people had no symptoms of CHS, started using these types of products, and now are experiencing some adverse effects. So I think that's an important thing for us to study too, as they become more available and more popular, to just understand if this is triggering people or if it's not, because they are acting in a similar way.
Yeah, it's confusing. I've had a couple examples where one patient had developed CHS. She had been to the hospital 5 times over the course of 6 months. And this individual decided to stop vaping. So they went to the hemp store, right? The CBD shop. And what did they pick up? A replacement, a hemp vape, also known as a Delta-8 vape. Now, when I talked to this family, where do you think we were again? In the emergency department, because the patient was still regrettably having it. And guess what they said? The hemp was helping, right? They got the hemp, and it worked for a few days because, again, maybe it's less potent than the THC or the Delta-9 THC. Somehow it floated them over a few days, and then you get the impression that it is better. And so it's a really complicated thing out there. But there are case reports, so documented scientific evidence, of a patient developing CHS from not hemp-derived, but from fully synthetic pharmaceutical cannabinoids, K2 spice, so to speak.
Okay.
And there's no reason to believe that anyone is spraying that product with insecticide, because it's typically like an incense that's dried and then sprayed with the drug. There wouldn't be a place for much pesticide, although, I'm open-minded to the way the world works. But the point is it doesn't really line up with the pesticide case. And also, interestingly, there was one-off case report with a little boy who had a chronic and complex seizure disorder. He was not, a normal little boy. He was quite sick, and he was on a ketogenic diet for his seizures, and they started him on Epidiolex. I might have just switched.
CBD.
Anyway, the combination of both high-dose CBD, which is prescription strength CBD, extracted from the plant, and the ketogenic diet ended up leading to him developing CHS-like symptoms, uncontrollable vomiting that doesn't respond to medicine, from just the Epidiolex, which is CBD, almost isolate. There's like 0.1 milligrams in a dose, or 0.1 milligram maximum, but like tiny amount of THC, almost all CBD. And therefore, like, what are we dealing with here? It's not totally clear.
Oh, man, it's not clear at all, I don't think. So, yeah, I think back to theories one more time, because I do think it does make sense if you're adding so many cannabinoids to your body. Like, maybe it's possible that your body adapts by producing less, less endocannabinoids. And then when somebody takes a break from cannabis, whether they're on vacation or whatever it is, their body's not able to produce enough of those endocannabinoids, and that might lead to them feeling like they need to vomit, or like, that's kind of where my brain's
that sounds
at,
like
of,
dysregulation, downregulation. It's pretty well established.
Yeah.
I was in the literature doing my weekly posts, and I stumbled across nausea, stress, and the ECS, and kind of like it linked everything together, and it very much showed that this increase in nausea could be from a downregulation. If the ECS is helpful to your nausea, and you can take THC and it helps your nausea even more, chronic exposure to THC sucks that receptor inside of the cells. Now there's less satellite dishes to receive the signal. You have less anti-emetic or anti-nausea, let's call it bandwidth or range.
I like that. Yeah.
It's possible.
Can we talk about what helps people with their CHS symptoms, and maybe why, if we have any thoughts on that?
Yeah, I'll jump in. What I have learned and seen, and it's, of course, is different for everybody. I'll let Codi talk on the medications, but supplements that we have seen help people are like magnesium glycinate to help kind of like calm and regulate the nervous system, to help with that anxiety. Digestive,
taken orally, right? Not because you can add magnesium topically as well.
Right, and I'm curious if that would help. Should we add that in our study? Topical magnesium.
It probably won't hurt. That's for sure.
Right. Yeah, for sure. Like digestive enzymes to help people, because this can like wreak havoc on your GI system. Like, I know that Katie, our nurse teammate, she gets pictures of people's stuff all the time, and it's not like normal poop. So digestive.
Oh God, that's what you mean by people's stuff. I'm like, oh, they're like their charts or what? No, okay.
No. Yeah. And I have like gotten photos as well from CHS patients, and it loose stools, constipation, like can wreak havoc. So she suggests digestive enzymes. Codi, and what medications do you see in the ED?
Wait, can we talk about Can we talk about capsaicin?
Yeah. Let's talk about
before we talk about medications. Okay, cool.
Hot baths,
Megan,
that's the thing. Is like patients often report this. I would say well over half of patients that I talk to do report significant relief. The only time they feel okay is in a scalding hot bath or shower. As you might imagine, this comes
like to the point of burning their skin.
Yeah, we have seen patients,
and they'll post photos
boils on their skin. Yeah, I mean it's anything. If hot water is good, like the brain pretty quickly goes, well, scalding is gonna be better. And they're in such immense pain in their stomach. Any even distraction from that, I think, can be a lot. But very hot water, doesn't have to burn them, but certainly we've seen that in occasion. And it's really only short-lived. They're only feeling better whilst that water is actually hot.
While the hot water is like on
and
the
this
body.
is hard for patients because they get lightheaded and you can't stand in the shower all day, and how much
you're already dehydrated.
In the hospital.
there's no bath in the hospital, but I do have patients sometimes go to the hot shower. So that is one thing that patients definitely do to feel better. And because of that, the heating pad has become a regular recommendation as well. So not bathing and showering all day, but putting the warmth around the primary point of our issue, that helps people a lot. Megan mentioned the digestive enzymes to help with food, and maybe magnesium to help calm the nervous system. Other things people have reported. Again, we're asking you guys like what has worked for you, but this is what we've heard, and so we ask you about these things. Sometimes Benadryl or antihistamines can be helpful for individuals to just take the edge off or break it. And then like avoiding certain foods, people, there's not a lot of evidence to support what's called the trigger list of foods. But there's certainly something to it. Patients are very sensitive to food, and spicy food in particular, while they have this condition. Alcohol's a really good example. I see this with some regularity as well. Oh, I was out with my friends last night, and here I am today with emesis.
Okay, wow. And one more thing about the hot showers too, capsaicin cream on the stomach, because capsaicin is the active ingredient or compound in hot peppers. So putting that as a cream on your stomach activates the same receptors as a hot shower does. So hot pepper and hot showers activate those TRPV1 receptors, which have been shown to help people with these symptoms. Do we know why that is? Why these TRPV1, or a theory of potentially why this receptor is involved with CHS at all? Pick me.
So I'm doing a talk on this basically coming up. But TRPV1, the capsaicin receptor, is now, it's basically been lumped in with the ECS. It's a CB1, CB2 type of receptor. The new definitions are strong in this direction. And a lot of receptors like that one that are sensory or thermoregulatory receptors also appear to have a lot of crossover with the ECS. So it's probably our growing knowledge of the system and its masterful complexity that is really driving us to consider these other options. And I would say, it's not, maybe TRPV1 is not the only answer, right? Like mustard oil interacts with a receptor, and menthol interacts with TRP receptor. Maybe there's something more here that is totally unyet explored around topicals. We just sort of threw the arthritis cream. This receptor
has been largely implicated in the driving cause of CHS. Also, that's one theory, is downregulation of these TRP receptors, right? That one paper thing.
Yeah, I think that, I'm not sure which came first, the benefit from capsaicin because of the hot showers, or the theories around TRPV1 receptors, but definitely one of the leading theories is TRP dysregulation, and so this secondary signaling system. What other theories are out there? There's one related to the cortisol system, that the cortisol system becomes out of whack, and that's what's contributing to this imbalance. Again, all of these are mostly hypothetical based on what we've seen in patients. And
all are linked to the ECS, because the ECS is just intertwined with everything. So it's definitely involving the ECS in some way, but the exact mechanism remains a mystery. But honestly, from the data we get from this study, it's going to help us think of better, more accurate hypotheses and theories to then pursue further with laboratory tests and analysis, and maybe even genetic tests as well. So, this study is really like step one, and then it'll allow us to continue getting information about this. Codi, can you talk about what pharmaceuticals in a hospital setting that are prescribed to people who are suffering from CHS? I know you said that the classic antiemetics aren't working well. So is there anything that is, other than abstaining from cannabis?
So typically we use a medication for almost all types of nausea, vomiting. It's typically called ondansetron, or what's also known as a serotonin 3A blocker. Okay, so we're specifically targeting serotonin, and that typically blocks the average nausea and vomiting, even nausea from chemo, gastroenteritis. It really helps to block the serotonin, which stops the induction of vomiting. So that should work for most vomiting. However, in the case of CHS, it doesn't do much of anything. The vast majority of patients find no effect. There have been multiple reviews. Everybody gets it because it's the go-to in the emergency department.
Yeah.
And it just doesn't seem to work. So scientists have thrown darts and doctors have thrown darts, and they've tried to review what darts. And there really haven't been very many that stick. The typical next line agent that's used is typically something known as metoclopramide or prochlorperazine. Both of them are antiemetics, nausea medicines, that instead of blocking just serotonin, they act on dopamine. So they're going to block the D2 receptor, and hopefully that helps take the edge off the nausea vomiting. We'll give these medicines frequently for like a headache that's accompanied by nausea vomiting. We'll give it for GI distress unrelated. Once again, it doesn't seem to work. They've tried a bunch of stuff. They've tried promethazine, which you've probably heard of, the primary ingredient in scissor. They've tried all sorts of antiemetics, but really what they've only found to be working is sort of a throwback drug, one or two medicines that fall into the original antipsychotic category. And instead of just blocking some serotonin or some dopamine, they kind of indiscriminately go and block a bunch of receptors in the brain. Okay? And that's why they're old and sort of what we would call dirty. But they also work for a lot of conditions and are still in use today despite being developed in the 1950s. Now, this is called haloperidol or droperidol. These medications can be extreme.
Haldol.
Haldol is the brand name typically that you'll hear. These medications are usually what we get to after Zofran and chili oil don't seem to help you. And if we get you there, we are going to give it to you IV. And it is a very sedating medicine that can make people feel a little different. It's changing your brain chemistry pretty profoundly when you get it. However, it freaking works. And patients come back begging for it. They're like, please just help me with the haloperidol. Don't mess. No, you can take that chili oil and shove it up your ass. Like, I need the haloperidol. Don't do that. That would burn because you have TRP channels in your booty too.
I was literally just thinking that because Meg and I were talking about suppositories, and I'm like, ow, that would be like the most painful suppository ever. Chili oil.
Yeah. Well, this is how I teach it. I'm like, and you have all these sensory receptors in your mouth and throughout your GI tract, right? Because the next day, you also had something spicy.
I was going to say, I think a lot of people know from their lived experience about
I love spicy food, but I don't always love the day after spicy food.
Great anatomy lesson, though. Now we
TRP
know.
channels, part of the endocannabinoid system, are distributed throughout all of your mucous membranes on your eyes and your mouth and, all sorts of places. We got off topic, I think.
No, but that was a great answer. That was about pharmaceutical drugs that are prescribed for people suffering from CHS. And now for both of you, question, because I know, Codi, you've been mentioning that you work with people 18 and younger. Megan, you mentioned a 17-year-old. Is this something do we know anything about the age distribution? Is it happening with younger people more than older people? Is it just a product of younger people using more concentrates? Do we know anything about who's suffering from this the most?
I think that it's happening faster in younger people, either because, meaning like they're using cannabis for a shorter amount of time than a cohort that's in the older age. That's because their ECS is like still developing and sensitive, or they're just using concentrates at a higher rate. In people our age and older, what I see is I've been smoking flower for 10 years and then developed symptoms, or, I've been using concentrates for 5 years and then developed symptoms.
We have patients who've smoked for 30, 40 years on these Facebook groups, 40 years, but has been feeling unwell for 20. Right? And didn't know what was going on, never heard of this crap. And as soon as they learn about it, light bulb moment, oh my God, that's what's been afflicting me this whole time. And sometimes those people are growing their own weed, right? And so their pesticide doesn't make sense.
Right.
Sometimes they're going to the store. Sometimes they're still in the illicit market. But we've seen it kind of happen all around. I do agree with Megan that is the trend on what I've seen, maybe what I feel. If we look at the data, if we look at what's been published, we see the highest rate appears to be that 18 to 25-year-old. And I believe male is what the data is. But my experience has been it's
That's also the main people consuming cannabis, right? Like that is the
and like people who are
distribution
smoking the most cannabis because maybe they don't have a job, they're just in college, or there's a lot of I think reasons why that might be. I personally have not seen a strong male correlation. I see a pretty even distribution in my patient population. But again, as a whole, men tend to smoke more cannabis than women, or at least the number of men smoking cannabis regularly is higher than the number of women smoking cannabis highly. So for that reason, I think that there's probably some correlation there, but hard to say who. What we know is it can take everybody. We've seen 80-year-olds, and we've seen, this crazy case I told you with the CBD, which is not the same thing, but he was like 8. So like, it's not like it can't occur in this whole spectrum of problems.
Mm-hmm.
Right.
Okay, yeah. I'm going to ask a Patreon question. We've kind of covered this, but I think it's good to explicitly answer this because it is a big question a lot of people have. So this is from Neil Devine. He asks, is this related only to certain potencies or how often somebody uses cannabis? Would mixing in CBD help? And I think that means would it help not develop CHS or trigger it? Like, would it help in a preventative way? And I would say yes, like always mixing in CBD and reducing the actual potency of the amount of THC you're putting in your body. We talked about the entourage effect. If we can just produce other chemistry with our products and touch on more receptors than just absolutely slamming the CB1 receptor, I think that's a great way, like a preventative mechanism, but we don't have the data to back that up. But what would you guys say about that?
In treating patients with cannabis or educating patients about cannabis, my goal is to achieve their goals with the lowest amount of THC possible. So, if it only takes them like 5 to 10 milligrams to achieve like pain relief or help with sleep, like we want to stay there. Even for cancer patients, I'm hitting them with like high concentrated CBD and CBG. We aren't going with the Rick Simpson protocol of 90 grams in 60 days or
crazy doses
opposite,
of
whatever
THC
that is.
that are very
inebriated. It's high concentrated THC. And I've heard stories of cancer patients doing that protocol and then developing CHS. And if you're a cancer patient and you have CHS and you can't use cannabis,
not ideal.
That's
We've
tragic.
lost a
That's
tool,
terrible.
and a really useful one.
Yeah.
You've lost a tool. So my goal is to always stick with the lowest amount of THC. What else can we use to manage your symptoms? There are 100 other cannabinoids that can do amazing things for us to help manage symptoms.
Yeah, I love that.
So I would say for the person who has not yet developed CHS, it may be reasonable to integrate mixed varieties, type 2s, reduce overall THC exposure, and, try to still derive the same benefit, and maybe get some of those benefits from CBD. As far as those people who've developed CHS, this idea of like, just switch to CBD or reduce your THC with CBD, this would be a mostly failing effort, I believe. That's opinion, not fact, right? We haven't done these experiments. No one's making people smoke something till they vomit. And so we've seen too many people react to CBD, especially with like a 1-to-1 or even a mix with some THC. I think once you've gotten that out of whack, we need to reset the scales. So kind of bringing it back to like a period of abstinence and then reconsidering where the calibration is and if you're someone who can tolerate THC versus not. And this is what I tell all of my patients. I need 6 solid months from you, a young person, and you're going to feel way better in 6 months. You're going to feel like a new person. And then with that renewed self-confidence, you can go experiment with THC, but you need to know you're never going to smoke like you did. And this can come back at any point. You need to be thoughtful. You need to be conscious and thoughtfully, mindfully consuming your cannabis. And that's not the worst lesson, even for somebody who doesn't have CHS.
I would agree. Everything in moderation.
Yeah.
And I think that I want to revisit, Codi, you were talking about stigma, and I think we're getting towards the end of this episode. I think it's really important we touch back on this because people do use CHS to fearmonger. People do use CHS to say that, cannabis is harmful to so many people. And it really, I think we do need to shape the conversation a little better around CHS because cannabis is so safe for most people. But as we were talking about before, it's not safer than water. It has hundreds of bioactive compounds and they are acting on your body, and too much of anything is bad for you. So I just wanted to reiterate the stigma point because we're not trying to perpetuate any stigmas with cannabis here. As we mentioned, we're all cannabis consumers. We want to make sure that people aren't developing CHS and they're using it in a responsible way. But CHS is very real and people are suffering from it. So it is worth giving them the validity, but also not taking away from people thinking that everybody's going to get CHS if you rip a dab.
That's hyperbolic. I've had people reach out to me. I'm so scared of developing CHS. And I tell that individual, I need you to breathe, okay? And there's no reason, if anything, you're setting yourself up for this by putting it in your head and wishing it into existence. I take that with, some of it, I joke a little, but we shouldn't be stressed about things that are out of our control and in the future that haven't happened yet. That is just not a great way to live. That's just life advice. Take it and carry it with you, audience. But from a stigma perspective, we have a few different angles in this, and I want to address all of them. Number one, healthcare provider stigma. Okay, our doctors need to lay off. They need to not think, this person's some addict, therefore they develop CHS. There's a genetic component. That person probably is deriving benefit. Get a life. Don't jump to a conclusion. Ask them questions. How long have you used? How long, how long have these symptoms? Has it ever happened before? Have you ever thought about it? Have you ever had prodrome symptoms? Ask those questions. Don't just throw a diagnosis. So doctors, drop the stigma and the bias. Second person that needs to drop the stigma is the damn industry. This is a real condition that's affecting real people and unfortunately has taken the lives of certain individuals because there's not acceptance, there's not awareness, etc. So the industry needs to be willing to accept that people can get sick, especially if we're not taking the right care or doing the right education, and that we need to do a better job as an industry. The last person that needs to I think, drop the stigma would be us when we're talking about it, or check our stigma, is yes, this is a concern, but we need to talk about it in a tempered way. We don't need fear mongering. We don't need to claim we know everything. Maybe it's we know nothing. Maybe it's a cannabinoid we've never even heard of showing up in these. I don't have the answers.
So
and we need to check that. And that's the healthcare professionals too, is what are we going to do? And what is the actual solution? We got to work as a community to get there.
I love that, Codi.
Agreed.
Thank you for including that. That's so important. I would reiterate the thing about the industry. We are not doing ourselves a service when we are pretending CHS is not real as the industry. We are the experts on cannabis, and we need to treat this as a real thing, especially this is community medicine. It's always been community medicine, and we need to look out for our community. If somebody tells you that they're experiencing these vomiting episodes, you need to share information with them. You need to tell them that it might be CHS and that they should stop using cannabis. So that's important too. But thank you so much for that. I think we should repeat just one more time the different phases of CHS, from prodrome to hyperemetic to recovery. Say our survey one more time, and then we can be on our merry way.
Yeah, okay, I'll cover prodrome. Prodrome can happen weeks to months to even years before the first vomiting episode. And oftentimes prodrome symptoms include waking up with morning nausea and anxiety. People can develop an alcohol intolerance. They just don't feel well. Sometimes this happens when people have gone hours without cannabis and they're kind of dipping into the abstinence or withdrawal effects of cannabis. They start to feel these symptoms. This GI upset, heartburn is really common. One of the most common medications people are put on right away is a PPI. We're not supposed to be on PPI for long periods of time. And so then people can just feel like shit for a number of months or years or even decades prior to developing the first hyperemetic.
So prodrome can last decades. It can last a really long time. It's not you get 1 week of prodrome, immediately go into hyperemesis and then from there it can be like a varying amount of time?
I think so.
Yeah, definitely. And it's not set, and it's not clear which of these symptoms you're going to have. And so everyone has a bit of a different, and it's not always abundantly clear that people who are in prodromes, they often don't recognize it. But this is why awareness is so key. We can educate people that if you're a daily or near daily cannabis consumer, and you're waking up with this heartburn, this indigestion, diarrhea, anxiety, hot and sweat colds regularly, and you're consuming cannabis, probably from a vape pen, not necessarily, but like you probably need to consider, could this be a thing, and how can I approach this? Can I temper my use? So I think that that's really important on the prodromal side. Then, for whatever reason, a trigger, maybe a food, maybe alcohol, patients go from a prodrome, which is sort of the pre-symptoms, into the hyperemetic phase or the vomiting phase. And the vomiting phase, we already talked about it, is characterized by intense nausea and vomiting. It's not like, oh, I just burped up my lunch and everything, I feel better now. No, it is hacking up everything, dry heaving, just wanting to curl up into a ball and cry. Sometimes also associated with similar like hot and cold sweats that we talked about, shivering, like we said, screaming while they're vomiting, just a lot of uncomfortability. And this can last kind of regardless of how long you'd been smoking, but can last from anywhere for a couple hours to a few days, as long as a week in severe cases. What does typically happen is it gets longer and more severe over time, but that's also what are you doing on the backside, right? Are you continuing to consume? Are you reducing consumption, etc.? So it's not that straightforward, but just know that it's likely that this is like almost like a relapse remitting disease that comes back a little bit worse each time. And that's what we see in the majority of patients.
Okay. And then there's the recovery aspect where you're not using any cannabis products and you're just trying to get your body back to normal as you're abstaining.
Yeah, and that one's kind of complicated too, because it's going to depend on, did I stop consuming? But most of the time, people are so unwell during their hyperemetic phase, they're not touching cannabis. Right? Like they can't even like get to that point, even though it's been helping them for so long. Maybe even they don't even believe it's the cannabis. They just feel so unwell that smoking doesn't even sound appealing. And so those individuals often are already sort of abstaining and potentially on that path. But if they don't believe it or aren't aware that it might be cannabis, then they're probably going to fall back into the pattern of consuming, then the prodrome, and then the hyperemetic phase again. And it kind of runs in a circle that way.
Yeah.
Thank you. Yeah. So as we mentioned, the study, the survey, it is quite long, but it is you contributing directly to cannabis science. It is anonymous, so it's not like we're going to be, pasting your name all over the place. But if you do want to win the money, you will have to enter your name at the end. But that's not like we're not using your name for anything else. As I mentioned, though, it's going to take you a little while. So grab a blankie, grab a cup of tea, sit on the couch, get comfortable. And we really, really appreciate anyone taking the time to complete the study. It means a lot to us as researchers, and we just appreciate your time a lot. So if you guys have anything else to say on CHS or the study or what people should be prepared for.
Just on the study, this has been my baby. I really appreciate Riley and Megan, first off, for having this podcast and being my friends, but also for their help on this project. I also really want to, and the rest of the team, that's Jackie, Katie, and Jill, thank you so much for your contributions as well.
Thank you.
With respect to the study, just a reminder, we are trying to incentivize your participation. We know that taking 20 or 30 minutes out of your day times 2 is going to be a significant task. We also hope that you're passionate about this enough to share, but to try to help make it better, we've got 2 raffles, one for the part 1 of the survey, one for part 2. 3 people who take the survey will win a $100 gift card. I don't know what the odds are, but it's guaranteed to be better than 1 in 1,000, which isn't too bad. But it's going to be way better than that, unless we get hella good participation because this podcast blows up and everybody signs up.
Right.
But please share this with your friends. We're looking specifically for people who have been diagnosed with CHS or who believe they have CHS, okay? So if you have a friend, please send them the flyer that will probably be linked in the show notes, or at least the link. There'll be a quick description, a consent form, and then a bunch of questions. really, we cannot do this without you. And I really appreciate every minute that you spend helping us help other people and help improve diagnosis.
I also want to say, Codi, you've done a fantastic job as your first time being the principal investigator on a study. So, clap for you. It's not an easy thing to do, and you've done a great job organizing the team, getting everything together. And we will be writing this into a peer-reviewed publication after we get all of this data collected. So we will be sharing that as well. But just pat yourself on the back, Codi, because I know it's been stressful, but you've done an amazing job. Yeah.
Okay, I have one question from Facebook, then we can jump off.
Yes, nice. Live engagement.
Yes. All right. So my 15-year-old GI doctor is saying that my child is suffering from this. They have been vomiting for 2 years. They didn't smoke then, so we are stuck. The doc has pretty much wrote us off. We don't know what to do anymore.
Oh, I love that. This is such a good example question. This is something I'm always counseling my doctors on. When did this start, right? Because especially with my patients, because I'm dealing with 15, 16, 17-year-olds. When did this nausea vomiting thing start? I had one doctor thought it might be CHS, had called me over. Come to find out, the patient benefits tremendously from smoking THC and has had this problem preceding his adoption of that plant medicine. And so it was a no-brainer, not CHS. So in the case of what you're describing, it sounds much more similar if your 15-year-old developed this vomiting cyclic vomiting disorder before starting THC. Sounds much more like cyclic vomiting disorder, which is a similar sort of like broader category of vomiting disorders. And that's the stigma that I'm talking about, is like, oh, this kid smokes weed.
Do we know what causes that disorder, the cyclical vomiting versus CHS? Like, do we know what could be causing that?
We don't. It's not a well understood disease.
Okay, so I had to do this for a school project, and like the cause of CVS it's oftentimes like correlated with childhood stressful events, maybe childhood trauma, kind of like this psychosomatic thing that happens with kids, that like that's their manifestation of the stressful events is CVS. And cannabis oftentimes helps those with CVS, whereas in CHS it will make things worse in the long run.
Yeah, it is interesting because I think immediately to like PTSD and changes to the endocannabinoid system. And then, so then I'm thinking, wait, is then cyclic vomiting potentially like a ECS irregulation, just like the other direction?
Very well could be.
So cyclic vomiting syndrome is a larger category. CHS is technically a subsect of cyclic vomiting syndrome. I'm not medical advice and I'm shooting from the hip here, but it sounds a lot more like cyclic vomiting than it does cannabinoid hyperemesis to me.
Is CVS, do people experience the vomiting? Well, sorry, let me back up. With CHS, a lot of the symptoms are in the morning. Is that the same with CVS, where a lot of those symptoms are in the morning as well?
I've never seen that data. I've never seen that correlation, so I'm going to guess probably not. One thing that is definitely different is the occurrence of it in childhood. People develop CVS as kids usually. And often if their emesis, their prodrome, is characterized by a headache, which is much less common in our population that we're discussing today. Not to say it couldn't happen and that's the definitive. The other thing is, and I've seen mixed results, is the hot baths and showers seem to be more strongly correlated with cannabinoid hyperemesis as opposed to traditional cyclic vomiting. So I think those are some differentiator points for our medicine friends.
Man, fire question.
Yeah, somebody asked, is it permanent? We kind of covered this a little bit.
Great question.
Well, we think it's partially genetic. So in some ways, definitely. But we also think it's like sort of like dose and exposure related. So in that way...
So sometimes definitely.
Sometimes definitely, always. 35% of the time, half the time, every time.
Yeah. So likely, it seems like a component of it would last your entire life because you are genetically susceptible and you're clearly reactive to THC.
Yeah, but that dysregulation does not appear to stay sustained. And we do have patients reporting, and no evidence and not recommending this, that they can continue to consume cannabis with moderation or with thoughtfulness. Some individuals have just switched from indica or sativa, and it works for them.
I've heard a lot of people too switch from concentrates to flour. Like the flour doesn't bother them the same way the concentrates do. Again, this is not life advice. I'm not telling you if you have CHS to switch from concentrates to flour. This is just anecdotally from comment sections and from direct messages that I've heard.
Yeah, people are talking about this, and we need to create a safe space to talk about it and understand it better. And then we need to teach our doctors about it.
All right. Any other questions from your end, Megan, on Facebook Live?
We don't.
Tell our live friends thank you.
Yeah, thank you for asking those great questions.
Thank you, all
cool.
5 people. Yeah.
All right. Well, I think we've covered everything that I needed to cover in this episode. I really, really hope that people are sharing the study with people. Anyone you know who has suffered or is suffering from CHS, please share this. Please share the study link. And feel free to just continue asking us questions. All 3 of us create content about CHS, about the medical applications of cannabis and cannabinoids. We, all 3 of us are great resources in this community, and we will not judge you. We will not treat you in any negative way from communicating with us. So we want to be resources for you. So please don't hesitate to reach out. And I hope this episode is helpful for anyone suffering out there. And hopefully we can get to the bottom of this eventually through research, and your participation again is helping immensely, helping us understand this condition better and helping us treat people faster in the future. So thank you all so much. Mad love, and we will see you in a couple weeks. Thank you, Dr. Codi, and thank you, Megan.
Thanks, y'all.
Thank you, Riley.